Okay. Good afternoon. There is plenty of research showing that children who are conceived through medically assisted reproduction tend to come from advantaged families. And the prior literature has tended to attribute the social gradient in Mar births primarily to the fact that there are social disparities in access to medically assisted reproduction. So because those couples and women who have more resources are more likely to access medically assisted reproduction, then they will also be more likely to give birth through medically assisted reproduction. So we argue that this literature has potentially overlooked part of this association, and we argue that at least some of the social gradient in Mar births may be related to processes that take place after accessing medically assisted reproduction. So conditional on the fact that you start in medically assisted reproduction, are your chances to have a live birth through Mar different based on your resources and in particular your level of education? And so this is the key question that we aim to address in our study. So to address our research question, we use data from Finland, population register data. We look at all women who were born between 1960 and 1985 who underwent medically assisted reproduction to conceive their first child. We have a sample of 41,567 observations. By medically assisted reproduction, I mean all the treatments, so from ovulation induction to artificial insemination to IVF and ICSI. And the main exposure variable, which is the indicator of the woman's level of resources, is her level of education. So if she has less than tertiary or tertiary level of education. So this is administrative data, so we observe a limited set of characteristics of these women, but we try to make the most of the data that we have. So we control for the woman's age at the start of MAR, the partnership status, if she took antidepressants prior to undergoing MAR, household income quintile, when she started the treatment, and the region of living. So moving on to the results, so we find that amongst women who access medically assisted reproduction, so who undergo at least one cycle of MAR, the chances of having a live birth are associated with a woman's level of education. So for tertiary level educated women, the predicted probability of a live birth is just over 70%, and for women with below tertiary education, that's just over 60%. The blue bars are showing the association which only adjust for the woman's age at the start of MAR. The red bars show how the association changes when we include adjustment for all the sociodemographic characteristics which I listed in the previous slide. As you can see, the social gradient attenuates on adjustment for women's characteristics, but only to a minor extent, so the social gradient persists. In the next 2 minutes, I'm going to talk to you about some of the additional analysis that we did to test mechanisms that might explain this social gradient. So first of all, we saw that lower educated women were more likely to discontinue the treatments, to drop out. So they started, and from very early on, they were more likely to drop out, even if they were still eligible for treatments. When we looked at the number of cycles and treatments they underwent, we found that on average, women underwent the same number of cycles. So this, in a way, doesn't support the idea that if you have more resources, you're more likely to give birth by MR because you undergo more cycles, because you can pay out of pocket when you are no longer eligible for subsidized treatments. But we don't find evidence for that. But what we find evidence for is that more educated women are quicker or more likely to transition to more invasive treatments, such as IVF and ICSI, which are more invasive but also more successful compared to lower advantaged women. So there may be differences in the MAR treatment pathways they undergo, and that may explain differences in their success rates. And finally, we test the idea that perhaps lower advantaged women come to the MAR treatment with worse underlying health, worse fecundity, and this may impair their chances of conceiving through medically assisted reproduction. And we find support for that by looking at women who undergo ART as their first cycle, and we look at their success rate after just one cycle, and we see that there are already differences between these two groups of women. So we find evidence that at least part of the social gradient in MAR births originate throughout the MAR process. We find that there is no evidence to support that this is the case because of number of cycles they undergo, but potentially higher rates of discontinuation may play a role, as well as differences in fecundity and possibly type of treatments they undergo. Thank you. Sorry.